Hello everyone. Thank you for joining Advize Health for our webinar on meaningful use and security risk analysis. I'm your host Maggie Stankiewicz, and I'm pleased to welcome you to today's event. Before we begin, I want to give you a little background information on Advize Health. At Advize Health, we analyze processes, create protocols, and implement solutions for healthcare entities of all sizes. We have been in existence for more than 12 years and employ more than 60 of the industry's top experts nationwide. Advize does not subcontract employees, so you can rest assured that your needs are addressed by someone who is specifically assigned to your organization. We offer many services, including healthcare compliance, medical documentation auditing services, and educational opportunities for a number of topics, such as ICD-10 training and clinical documentation improvement. Our priority and promise to the healthcare community is to always tailor our services to our clients' individual needs and provide cost-efficient services that every entity is able to afford. We have two speakers for today's presentation. Advize Health's Quality Assurance Specialist and Auditor Melissa Jewett will be speaking first, followed by Don Wachter from Compliance and Remediation Services, LLC. Today's presentation will explore the future of meaningful use, preparing for an audit, and the most common mistakes that have been identified when examining the security risk analysis process. Melissa will begin by going over today's agenda. At the end of the presentation, we'll also have time for Q&A. If you have questions during the webinar, be sure to submit them via the questions or chat text box in the GoToWebinar interface and send them to all organizers. And I will make sure that Melissa and Don have time to answer them at the end. Also, you can expect to receive an email with a certificate for 1.5 CEUs, a copy of the presentation, and a recording of the webinar within 3 to 5 business days. I'll now turn it over to Melissa to begin the presentation on meaningful use and security risk analysis.
Thank you, Maggie. As Maggie mentioned, I work for Advize Health, and I've been in the coding industry for a number of years. I have been coding and auditing for multi-specialties and conducting many different types of audits. I've been in participation with a meaningful use audit, but generally I do medical, surgical, modifier, and dental audits. We also have Don, as Maggie mentioned. He's on the line as well, and he's a graduate of the University of South Florida with a degree in accounting. After working several years as a CPA, Don moved into the investment advisory sector of the financial services industry, where he functioned in roles of administration, compliance, business development, and product and division management. Don has held multiple security licenses, including general securities, registered principal, multi-state, and registered investor advisor. He has managed and successfully grown 3 separate investment advisory businesses and experienced multiple SEC examinations. Our agenda today, we will be reviewing recent statements about meaningful use and related quality programs. We will discuss the audit process for meaningful use as it pertains to security risk analysis, discuss how to prepare for an audit, identify most common errors discovered by audit, and review the most common gaps identified in security risk analysis. To begin the presentation, we'll start with the future of meaningful use and the incentive program. The EHR Incentive Program was created to promote and encourage the use of technology. Stakeholders agree the goal has been achieved, as we've all seen the widespread adoption of EHR. EHR use has laid a strong foundation for interoperability. So is meaningful use coming to an end? I don't know if anybody on the line here has heard these rumors, but there was a lot of excitement about this at the beginning of the year. When CMS Acting Administrator Andy Slavitt announced in his January 11, 2016 address, the Meaningful Use Program as it has existed will now effectively be over and replaced with something better, Since late last year, we have been working side by side with physician organizations across many communities, including with great advocacy from the AMA, and have listened to the needs and concerns of many. 1 week after this announcement, the Acting Centers for Medicare and Medicaid Services Administrator and National Coordinator, Karen DeSalvo, clarified that the MU program is still in effect. Providers should continue to follow the current program. She further explained the new program framework outlined by SLAVIT will take time to develop and implement. We can take a close look at SLAVIT's statement, and looking at it closer, it may prove that the Meaningful Use program is not coming to an end. Instead, we should view it as a shift in vision and alignment with another program. Meaningful use as we know it is coming to an end, is what SLAVIT said. We will move away from rewarding providers for the use of technology and towards the outcome they achieve with their patients. The first outcome of EHR was implementation and use. So we see the new focus is to promote improving care delivery and outcomes. Other programs, such as MIPS, still rely on the Meaningful Use program as a means for measuring. SLAVIT described this new program in themes. He outlined that they will be moving away from the focus on rewards for the use of technology and focus instead on outcomes achieved with patients, specifically quality of care. The new program will customize goals. Tech companies and providers should be able to work together to customize according to their individual practice needs. And I would say that from the provider community, that is going to be welcomed. So there has been many reporting items in the Meaningful Use program that don't fit every provider's situation. The new program will be moving away from measuring clicks or achieving the government set criteria, and instead will be focused towards user-centered technology. The new program will require APIs, Application Program Interface, which is a set of programming instructions and standards for accessing web-based software application. Open APIs are touted to be the key for interoperability. So interoperability, this is a big focus of the new program. CMS Acting Administrator Andy SLAVIT's comments at this year's JP Morgan Healthcare Conference was, by leveling the technology playing field for startups and new entrants, we are requiring open APIs so the physician desktop can be opened up and moved away from the lock that early EHR decisions placed on physician organizations to allow apps, analytic tools, and connected technologies to get data in and out of the EHR securely. Andy offered, "We are deadly serious about interoperability." So another theme of the new program, we can expect changes in the payment models. Pay for performance and pay for value. The program, MACRA, Medicare Access and CHIP Reauthorization Act of 2015, has combined all the quality programs, PQRS, value-based modifier, and meaningful use. MACRA, combining the quality programs, streamlines and provides a payment system called MIPS, Merit-Based Incentive Payment System, and APMs, alternate payment models. MACRA, or MIPS, will quickly facilitate CMS's goal of moving to pay for value and better care. The timeline for the implementation spans 2015, so it already started, through 2021. MIPS and APMs. The new merit-based incentive payment system helps to tie fee-for-service programs to quality and value. You'll see here in this demonstration that quality plus the resource use plus clinical practice improvement activities plus meaningful use of certified EHR technology equals your MIPS score. So these are all the factors that will create the score and essentially the payment or the adjustment in payment for the provider. CMS is shifting the paradigm, so IT health becomes a tool for care improvement. Good news from CMS. So what does EHR 2015 and beyond look like? Well, the good news is MACRA eliminates the penalties in the EHR Incentive Program after 2017. The major changes in the EHR Incentive Program include 10 objectives for eligible professionals, including one public health reporting objective. So this would be down from a total of 18 objectives prior. 9 objectives for eligible hospitals and critical access hospitals, including one public health reporting option, down from 20 total objectives in prior stages. And clinical quality measures reporting for both eligible professionals and eligible hospitals remains as previously finalized. Continuing our look into EHR 2015 and beyond, we know that MU as we know it may be undergoing a change, but one fact remains: performing a security risk analysis is still an integral part of the program. You can see this identified in objective number 1, protect patient health information. Objective number 1 in the measure specifies conduct or review a security risk analysis in accordance with the requirements in 45 CFR, including addressing the security to include encryption of ePHI created or maintained in a CEHRT in accordance with requirements under 45 CFR, and implement security updates as necessary and correct identified security deficiencies as part of the EP's risk management process. So even with all the changes and the idea of the program coming to an end or morphing into a new program, security risk analysis is here to stay. Security risk analysis. So what is a security risk analysis? We hear that a lot. Providers, even at this stage in meaningful use, many provider practices don't know what it is. And other providers just feel that having their certified EHR technology that they've already fulfilled this requirement. So many professionals, EPs, have learned that this statement is to be true. Just having a certified EHR technology does not fulfill the security risk requirement. And this lesson is often learned following an EHR incentive payment audit. Here's a screenshot from a meaningful use attestation. So when a provider is attesting to their meaningful use, they are asked that specific question, which is basically the same paragraph that I read previously, that asks, have you conducted or reviewed a security risk analysis in accordance with the requirements under 45 CFR? And the provider attests yes or no. I'm going to turn this section over to Don.
Hello, everybody. Thank you, Maggie and Melissa, for inviting me to join in today's webinar. This is a very important topic. I've got clients all over the state of Florida and a number of them outside the state of Florida that are being hit every day with some of these meaningful use audits that are going on. There's a lot of confusion in the industry still, so thank you for giving me an opportunity to clarify some of that confusion, hopefully, and answer some of the questions that everyone has. A couple housekeeping notes on the next slide. Number 1, it is important to note that while the presentation discusses risk analysis in the context of meaningful use and the audits going on within meaningful use, it's also a requirement under HIPAA. And unfortunately, while the meaningful use audits have been going on for a few years now, the HIPAA audits were put in abeyance for a while until Health and Human Services decided exactly what kind of HIPAA audits they wanted to do. And they recently announced, this is recent as of 10 days ago, that they're now resuming the HIPAA audits, and they will release the protocols for those, what they plan to do in those audits sometime in the month of April. So not only do we have meaningful use audits going on that require the risk analysis review, but within 30 to 60 days, we'll have HIPAA audits augmenting that. The meaningful use audits are desk audits right now. So you get an email saying, hey, before we send you your money, or in some cases now that we've already sent you your money, we're doing an audit and we'd like to have the following information. So you have a series of email exchanges. The HIPAA audits that are coming will be a mix of both desk audits as well as live audits. So they'll show up at your doorstep and say, hey, we're here, give us some space, give us access to the internet, and make sure somebody's available to answer any questions and retrieve any documents that we ask for. And as the early slides showed, my background is in the financial services industry. I've been through several Securities and Exchange Commission audits, and they're pretty ugly. They last a week to 2 weeks with the field person in your office. And I spoke with a healthcare attorney recently, and his comment to me about the upcoming HIPAA audits was that if you've been through an SEC audit, you should expect these to be similar to that. So I think things are going to get much more interesting over the next several months to continue the path toward increased fines, penalties, and enforcement of the laws as they exist. On the next slide, a little bit of background on how this whole process started. In 2012, the Office of Civil Rights, which is the enforcement arm of HHS, hired KPMG, the international CPA firm, to do a pilot program. Those program results ended, and the conclusions and findings were assessed in 2013, and the findings basically said, hey, guess what? Practitioners, number one, are largely non-compliant. People are not complying with HIPAA regs. And the most common issue of all that we looked at is a failure to perform a security risk analysis. So on the next slide, the recommendations were, number one, let's go ahead and increase the number of audits that are being done, because without enforcement, there will be no compliance. Secondly, let's narrow the focus to a few key items rather than overwhelm people with the scope of these audits. We're going to narrow the focus to half a dozen or maybe 10 key items, most importantly including the security risk analysis. And then thirdly, they recommended, KPMG recommended that the government develop some in-house resources to conduct these audits, because they're not going to go away. As an interesting side note, for every dollar that the government spends on conducting audits, they get an $8 return on their investment through fines and penalties that are assessed. So this is a very lucrative process for the government to be involved with. On the next slide, so as all this is going on and the recommendations are being reviewed, the Omnibus Rule takes effect, which was enacted in March of 2013 and became effective in October. And some of the key features of the Omnibus Rule were that, number one, it increased the authority of CMS. It expanded the enforcement authority of the Office of Civil Rights. It increases fines and penalties. It shifts the burden of proof in the event of a misuse of patient data, protected health information. It shifts the burden of proof to the covered entity. That's a very important and very significant point. So if there's been a misuse, it's up to the covered entity to conduct an assessment and determine if they can prove beyond a reasonable doubt that none of the patients were harmed. So whereas the normal American jurisprudence system says you're innocent until proven guilty, this law is different. It says we presume that harm was done unless you can prove otherwise. A very significant change. And it also said, as a final point on this slide, that business associates are now subject to audit just like a covered entity. So anyone that sees protected health information as part of their doing business with covered entities, the most common example I think is probably an IT company that comes in and does work for a medical practice on a regular basis. They're a business associate and they can get audited under this new audit program just like a covered entity, and they have to acknowledge that they have to comply with all the rules of HIPAA just like a covered entity. So on the next slide, what's going on today, given that kind of a background? Figliazzi and Company out of New York City is a CPA firm. They were the ones that were hired to do the desk audits for meaningful use. They've done hundreds of them. I've got probably 20 or more clients that have received that audit notification from Figliazzi, and we'll get some language in just a couple more slides, but it's pretty straightforward. The end results of the audits that they're conducting are that 2/3 of the audits they're doing have at least one finding or more of deficiencies. The most common deficiency, and this is no surprise because this is exactly what KPMG found, is that people are not doing security risk analysis, or they're not doing an adequate security risk analysis. And an important point with respect to security risk analysis when you attest for meaningful use is this: if you do not perform an adequate security risk analysis or do virtually nothing to really have that performed, that's called false attestation, and under the law, false attestation is a felony. You can go to jail for it. There was an example of a hospital in Texas just 1 year ago, almost to the date, where they fell short. They got audited. They fell short of meeting the requirements for meaningful use. It was considered a false attestation. The chief financial officer was sentenced to 23 months in jail and fined $4.5 million. The physician owner was only fined $100,000, which is small by comparison to the $4.5 million that the CFO got fined. But the physician owner was sentenced to 11 years in prison. So the fines, as I mentioned, are being enforced rigorously, and they can get very severe very quickly. On the next slide, here's some language from what these clients are getting, my clients are getting, physicians. For measure number 1, this is similar to what Melissa talked about earlier. Measure number 1, protect patient health information, provide proof that a risk analysis was performed, and here's some key language: no earlier than the start of the reporting year and no later than the date of attestation. I'm going to come back to that in a few more slides. So you got to show them the report that documents what procedures were performed during the analysis and the results of the analysis. So you can't just go through a checklist. This gets fairly complicated if you've never done one or seen one. If deficiencies are identified in this analysis, please supply the implementation plan. It's got to include completion dates. Now that language has just changed in the last couple years to become much more restrictive than what they were doing as recently as 18 or 24 months ago. Next, and we'll come back to some of this language in a few more slides, as I mentioned. Okay, so given that that's what's going on, how do you prepare for an audit? On the next slide, so they're doing these meaningful use audits, and Melissa is the person to talk to with respect to everything about that audit except the security risk analysis portion of it, and that's what they asked me to address. So in short, you know, she's going to say make sure you get all the qualifications in writing, including screenshots of various measures during the qualifying period as appropriate. Also, my advice to all of my clients is make sure you're working very closely with your advisor, Advize Health in this case, to make sure that documentation is complete. Because I see a lot of people on a daily basis who are doing the right things but not documenting appropriately. And when it comes time for an audit, you know, if you say, oh yeah, we're doing this, or yeah, we're doing that, that doesn't cut it with the government or the auditors. You have to show written documentation that those plans and procedures were put into place and the dates that they were put into place. On the next slide, so okay, given that language, how do you prepare for an audit? With respect to the security risk analysis portion of the audit, make sure that you have, and here I'm going back to the language of the audit letter, that it's dated after the start of the reporting year and not later than the date of attestation. That documents the procedures performed. So you got to, in that document, show them what kind of protocols were used in performing the security risk analysis. I'll expand on that in a few more slides. This document has to show the results, the findings and recommendations, and it also has to document the implementation, also known as a remediation plan, importantly, including dates for completion. So they not only want to see a risk analysis, they want to know what the findings were, and they want to know what your plan is for remediating the gaps that were identified and what dates you plan to have that remediation completed. So this gets very restrictive under today's standards. On the next slide, you can perform your own security risk analysis. I have a number of clients that have done it or tried to do it, and gotten partway into it or been denied their incentive payments because it was inadequate. But if you do choose to perform your own security risk analysis, it's really interesting, some of the language contained at the CMS website. And here's one that I copied just recently. Quote, "It's possible for small practices to do risk analysis themselves using self-help tools. However, doing a thorough and professional risk analysis that will stand up to a compliance review will require expert knowledge that could be obtained through services of an outside professional." So this, again, is new language that's come up in the last probably 18 months or so. And a lot of people were doing self-assessments when this program first came out. And now they're finding a lot of deficiencies in those assessments, and they're telling people not so subtly that if you're a small to medium-sized practice, you really ought to consider the services of an outside firm. On the next slide, along the same theme, you may perform a self-assessment. If so, number one, recognizing that if you do one, it's probably going to take a staff member in a small to medium-sized medical practice hundreds of hours to complete a quality assessment and identify deficiencies. It will probably take much longer than that to remediate the deficiencies, depending on how complicated they are and for how long you've been had a rigorous compliance program in place. But a good starting point, if you want to do one yourself, is HHS on the website. If you just type in HHS self-assessment, Google that, that'll direct you to 3 different documents. The first one deals with administrative safeguards, 185 pages long. Second one deals with physical safeguards, that's 99 pages long. And the third one, technical safeguards, at 135 pages. That'll get you started. So that's how to move on from a starting point. On the next slide, I talk a little bit about if you're doing a self-assessment tool, you not only need to do the administrative, technical, and physical safeguards, but you need to make sure that you're incorporating generally accepted standards and protocols recognized by a respected organization whose purpose is to define how risk analysis gets performed. There are several out there, but the most significant one of the entire group is the National Institute of Standards and Technology. They are completely independent of CMS, but they have 2 key protocols that they have developed with respect to security risk analysis, that's 800-30, and HIPAA within the security analysis process, which is protocol 866. So that's your second point. You go to HHS website and get an idea what they're looking for. Then you go to the NIST standards. Alternatively, on the next slide, if you choose not to try to do one of these in-house and decide to get the services of an expert and probably save a lot of money in that process, I would give you a few cautionary notes with respect to who you choose to do a security risk analysis, because I run into this on an almost daily basis. Number one, check out what the firm does as its main line of business. Be wary of firms that don't have demonstrated expertise or their core business is not risk management or compliance. And I see a lot of firms out there that jumped in and suddenly jumped into the fray of the HITECH Act and said, oh, by the way, yeah, we're security experts and we're now HIPAA experts too. And by the way, we sell all kinds of, IT services, and that's our main line of business. And you can be sure that in almost all cases that I've seen where security risk analysis is a sideline to some other core business, there are some significant deficiencies in that entire practice. And one of the ways you can identify or kind of filter through some of the people that you might be talking to in terms of performing a security risk analysis, ask them very simply, what protocols do you use when you perform a security risk analysis? I had lunch with a consultant. He's been a consultant for a couple of decades, actually, in the healthcare industry, and he recently started doing risk analyses, and I said, what protocols do you use? And he says, oh, I just ask a lot of questions. So if you get a response like that, you probably want to keep on talking to more people instead of limiting and hire to a single person. The answer you're looking for, of course, is I'm looking for, I use the protocols established by the National Institute of Standards and Technology. Other things you can do, moving on to the next slide, is ask them to see a sample report. Our reports for the risk analysis portion of our work only generally range from 65 to 85 or 100 pages, depending on the nature of the client that we're working with, sometimes much more in depth, but for a small to medium-sized firm, that's the general report length. Ask them for references, of course. Have them sign a very well-crafted business associate agreement, because the great thing about business associate agreements is they give you a lot of protection. If there's ever an issue with mishandling protected health information, you need to keep in mind that the covered entity or the eligible provider is the one ultimately responsible under the law for being compliant in dealing with non-compliance issues, including breaches. So if you hire a firm to do work for you and they're a business associate, even though you can get a good business associate agreement with them, ultimately you as a provider are the one responsible for making sure that any kind of a breach is appropriately dealt with. Ask them, beyond the business associate document that needs to be well crafted, ask them what documents they provide to help you remediate any gaps that are identified in the risk analysis. So, the starting point is a security risk analysis. If the analysis says you don't have adequate, HIPAA policies and procedures, or you don't have a risk management plan in place, or you don't have an incident response plan in place, great, but okay, what are you doing to help me get there? So that's a very important question to ask anyone that provides these kind of services. And in conjunction with that, the final point on the slide is, what kind of ongoing support and services do they provide? Because HIPAA is not a one and done kind of thing. Compliance with HIPAA requires that you be on top of it on a very ongoing basis. And if you're testing for meaningful use, it's by law required that you either perform an analysis or you review a security risk analysis performed by somebody else every single time you attest. HIPAA says you need to do one, but it's not that specific in terms of how frequently. It just says it needs to be done periodically as appropriate. Okay, on the next slide. So we deal with clients all the time that have been audited, or we see clients that have had risk analysis performed by another group and later on came back and asked us to come in and do one on top of that as a follow-up. On the next slide, what are the most common errors that we see? I see a lot, believe it or not, I see a lot of people that have never really performed one. They might say they did, but there's no documentation at all that one has been done, or it might be a 6 or 8 page checklist. That good news is that's becoming less and less common now than it was 2 years ago, but I still run into it on a regular basis. More common is the second point, where security risk analysis was performed. It might have been done in-house, or it might have been done by an IT firm, or it might have been done by some other quote-unquote consultant, but it fell way short of meeting minimum standards. Therefore, send us the money back, or we're not sending you the money that you're claiming is appropriate. I run into those on a very regular basis. Occasionally I run into folks that have done one but not done one during the prescribed period. I had a client call a couple weeks ago, or a prospective client I probably should say, and say, we did one 3 years ago, but for a Meaningful Use Stage 2 attestation, we never updated it or anything. What do we do? And I said, well, you give them the best thing you have. You don't want to go back and backdate a document to that's fraudulent, and we could all go to jail for that, so nobody wants to do that. But you show them what you have and tell them what you've done since then. But that does happen occasionally. And then the fourth point, they did a risk analysis, but there's never any follow-up. This happens all the time. And my sense is that over the next 12 to 24 months, you're going to see the government audit programs come in and say, you did one, well, what kind of remediation actions did you take? And the reality is the clients got the results of a risk analysis and recommendations for remediation and stuck the plan up on the shelf because they didn't have time to do any remediation activities. So that's back to the point of what I said in a slide or two earlier regarding, what are you doing on an ongoing basis to help us get into compliance to the extent we're not, and help maintain compliance, once we've attained 100% of compliance with HIPAA. On the next slide, those are some of the biggest gaps I see in audits right now. Next slide. Within security risk analysis, when I do them, what are the most common things, and these are all very simple and straightforward things. We could get into some more complex things in a whole nother discussion, but for today's purposes, I'm just talking from a general standpoint, what I see in small to medium-sized practices on a real regular basis. With respect to administrative safeguards, what are the most common ones? Number one is inadequate information system activity review or audit logs. Clients are audit logs. I think my EHR system might provide that, but I don't look at them. What's required? So that would be high on the list. Lack of security incident procedures, or also you might identify as that nobody has an incident response plan, or a lot of people do not have an incident response plan, which basically addresses what do you do if protected health information has been mishandled? Is there a breach? Is there not a breach? I have to conduct an assessment. All of that is detailed in your incident response plan. A lot of people don't have them. Many people do not have any kind of contingency or disaster recovery plan, or if they do, it's not very well documented. Next point is insufficient identification of business associates and maintenance of business associate agreements. This is an agreement, as I mentioned a few minutes ago, that's extremely important to the protection of the practice, because it's in the business associate agreement that you identify the responsibilities of your business associate, and you also tell your business associate, if you mishandle any of my patient data, you're going to be on the hook. So it's extremely important to have a good, strong business associate agreement in place, and you are required by law to do at least a minimum amount of due diligence before you hire any business associate that may be seeing protected health information as part of the work they do for you. So a lot of times I see clients that don't have adequate business associate agreements or don't have the appropriate ones in place, or haven't even in some cases identified who all their business associates are. So that's a critical piece of the puzzle here. Next, lack of safety and security plan. That's just a basic plan that says what do you do in the event that we have a short-term emergency. Very few people have adequate plans there, and very, very few people have adequate emergency mode operations plan. Living in Florida, if we have a hurricane or tornado blow through over a weekend and the building has basically been semi-destroyed and is going to be down for 2 weeks while the reconstruction process occurs, what do we do? All of that should be detailed in the emergency mode operations plan. Moving on to the next slide. So those are all under your administrative safeguards. This and under the category of physical safeguards. Number one, insufficient documentation of facility access. Who gets keys? What do you do in the event of an emergency, and how is all that handled? I still see some people that aren't using decent sign-in sheets. I ran into a practice in South Florida just recently where they were sharing space, and the physician group that they were sharing space with had a login sheet and had the full patient names. It also had the procedures indicated on the login sheet, and that is a clear violation. I still see that on a fairly regular basis. You're also required under the law to maintain a visitor or vendor log. So you got patient sign-in sheets. You should have sign-in sheets of visitors and non-patient people that come into the practice. Next would be inadequate documentation of media, what I call media use, reuse, and disposal. You need to have an inventory of all of your systems and processes that contain or handle protected health information. So you need to have an inventory, and not only does the inventory have to say what you have, but who's using it, and if the use of that a piece of equipment changes from one staff person to another staff person, that should be documented. You should also have a policy that details how you get rid of any piece of equipment that contains protected health information. And those of you that read on a regular basis may know that very recently, last 6 weeks or so, in Fort Myers, Florida, a radiology company, this is all public information, was getting rid of x-rays, and they had 485,000 of them because they perform analysis for medical practices all over the country, and they had a disposal company come and pick up these x-rays. Disposal company left the facility with the intention of incinerating the x-rays. They hit a pothole on the street on the way to the incinerator. Back door of the truck opens up, x-rays fall out all over the street, and you have a major, major breach. It's going to cost many millions of dollars to remediate. So it's important to have a disposal policy, and more important to have a good one that doesn't put the practice at risk for those kinds of incidents happening. Another physical safeguard, failure to properly secure patient files. I'm in offices on a real regular basis, and they have a stack of files sitting on a counter right next to a common area where anybody coming into the practice would walk over and pick up files and walk out the front door. I still see it on a fairly regular basis. Again, not as often as I used to, like 4 or 5 years ago, but still see that on a regular basis. And a big one, failure to properly secure workstations. So when I'm in a practice, one of the things I do is I do a physical walk around. I physically visit every location of every practice of all my clients, and I often see workstations that are visible from a common area like a hallway that do not have screen protectors on them. And anyone could walk up, sit down in front of the machine, read exactly what's on there, and navigate through the whole system if they chose to do something. I could tell a couple horror stories of clients that have actually had that happen, but that's the subject of another webinar probably. On the next slide, so that's it, what I see on physical safeguards. The next slide, technical safeguards. The biggest thing, make sure you've got encryption. The great thing about encryption, number one, it's required under stage 2 of meaningful use, but the great thing about it is it offers the provider an enormous amount of protection. I'll give you one quick example. And that is, if you have, say, a laptop, for example, and it's stolen, it's left in a car overnight, stolen, if the data within the laptop is encrypted, you do not have a reportable breach. You have an incident, you do the investigation, everything's been encrypted. By law, you do not have a reportable breach. Regardless of whether it's decrypted later or anything along those lines, you don't have a reportable breach. So it's an enormous amount of protection. It's required by law. It's an enormous amount of protection. Under stage 2, you only have to have data at rest encrypted, but it's a good idea to get data in motion encrypted as well. A lot of firms that I see don't have documentation of what exactly their backup procedures involve, and so that's more of a documentation issue, and very few practices that I see, at least on the first time that I see them, have actually tested their backup. So it's great to have a backup in the cloud and all those kinds of things, but you're also required by law to perform a test to make sure that that data is really available in the event that you have an emergency. On the next slide, those are some resources. So that concludes my portion of this presentation. As Maggie and Melissa mentioned earlier on, I am available to answer questions once Maggie and Melissa conclude the next few slides. Thank you very much.
Thank you, Don and Melissa, for that great presentation. We are now going to open up the floor for a few questions, and I see that we already have quite a few good ones. I'm going to have the first question be for Melissa. It's in reference to slide 14. It states to please clarify the statement, MACRA eliminates penalties in the EHR Incentive Program after 2017. In CMS's PQRS national call conducted earlier this year, it was stated that beginning January 1st, 2018, providers will receive a negative 3% payment adjustment if they are not being meaningful providers. Melissa, could you provide some clarification on that, please?
Sure, thank you. That's a great question. So essentially, you're correct in that there will still be an adjustment for people who are not meaningful users, but it will not be a double adjustment. So if you are receiving an adjustment from the Meaningful Use Program, when the payment model of MIPS is in place, you're not going to receive a double adjustment. So what happens is, if I can go back to the slide, let me find it here, towards the beginning, that demonstrates, here it is. This slide shows under the new payment model for MIPS that there's 4 criteria that will create your score, and the score is how you'll be paid or your payment will be adjusted. And the 4th item here is meaningful use of a certified EHR technology. So giving consideration to the new payment model, you will have an adjustment if you're not a meaningful user, but you will not have both adjustments. Your initial penalty that you had from the Meaningful Use Program, it's just going to wrap into this one program now.
Thank you.
Sure, you're welcome.
My next question is for Don. Goodness, I'm sorry. If a shred company empties your shred bin by loading them onto a loaded truck that doesn't shred them on site, is that an acceptable policy, or should that be tightened up a little bit?
It's an excellent question. Our response to that is it's not a technical violation per se. What you're required to do is ensure the protection of that data. But, and that's great that they weren't non-compliant, but nonetheless they had a catastrophe that could have been avoided. So that's a situation where best practices comes into play. And what we recommend, in fact, we just wrote this in our March newsletter, And by the way, any of you can get our monthly newsletter if you just notify me on my contact slide, or Melissa or Maggie. We'll make sure you get the monthly newsletter. There's no charge for it. But we recommended in the newsletter that if you can, and it's practicable, to go ahead and make sure that your data is shredded on site. If you can't, do it yourself. If it's just too voluminous to do it yourself, then hire a company that comes to your site but shreds it on site rather than transport it. And unfortunately, while that might sound like an unusual, really unusual case, I've read about it a couple times in the past over the last several years, so it's not as uncommon as you might think. And just consider the fact that any time you put your patient data in somebody else's hands, they're not likely to take care of it and protect it at the same level you are. Hopefully, that practice, that radiology practice in Fort Myers, had a very strongly worded business associate agreement with that shredding company and the disposal company. If they didn't, they're gonna be out of pocket for the whole thing.
To carry off of that business assessment agreement, would you recommend that it's signed every year just to make sure everything is current and up to date? What would the recommendations be for updating that periodically in order to stay in compliance?
Absolutely. I mean, it should be, those things need to be monitored on an ongoing basis, and I mean, that would probably be one of the more significant, in addition to the encryption, which is always the number one that I try to stress in presentations like this. Yes, your business associate agreement, take another look at it. There are a bunch of them online that you can model after, but the one that we use, I got with permission. The original draft was for a hospital. It's very tightly worded, and it makes it very clear that if that business associate does anything to compromise patient data, they're going to bear the cost and the responsibility of notifying patients under the supervision of the covered entity. So that's a really key and critical point. And yes, I would recommend that they be reviewed at least once a year, if not on an ongoing basis. Or anytime you have a change in vendor or change in personnel potentially at the vendor, make sure your business associate agreement puts that business associate on the hook, not just for their own staff, but anybody that they hire to do a job on your behalf.
Great. We have one guest here who works for a mental health counselor who is not an eligible professional. They are a covered entity, and this particular guest does the security risk analysis quarterly. They're not eligible to contract with Medicare, but would they still be a candidate for an audit?
Everybody that has to comply with HIPAA is a candidate for audit. So yes, every covered entity is now a candidate for audit. And mental health is an entirely different realm. There are as I'm sure the person who asked this question is aware, there's a very specific set of rules regarding protecting mental health data. So we could put on a whole nother webinar about that, but suffice it to say, if you're in that industry, you've got to be especially careful to protect that data, and yes, you are subject to HIPAA audits.
Speaking of protecting data, how would you physically secure a tablet or a laptop for providers and nurses if they're used on the floor?
The National Institute of Standards and Technology has put out a paper, a standard on what to do with remote device uses. And again, that can get real complicated real fast. The first question is, who owns the device? If it's a small practice and the physician owner owns the device, it's pretty easy and straightforward to deal with. But in larger practices where you have staff people that have their own devices, like a tablet that they carry around with them or maybe bring home, and they want to access data after hours or on weekends or something along those lines, the process gets much more complicated, and security still has to be ensured. So we have what we call a remote device use checklist that we provide to our clients. If anyone wants it, just send me an email. I'll be happy to provide the checklist to you.
Great. We have one more question here. If anybody else has any additional questions, feel free to send them in now. Don, you mentioned protocols for performing a security risk analysis. Can you elaborate on those protocols?
Yeah, these are protocols that are, again, they're outlined by the National Institute of Standards and Technology. And real simply, and the thing you want to look for, your risk analysis has to contain these protocols in the document, how you did the risk analysis. They start with identifying the scope of the analysis. Step 2 is gathering the data. 3 is document potential threats. 4 is assess current measures. Number 5 would be determine the likelihood of a threat occurrence. 6 would be determine the impact of that occurrence if it did happen. Therefore, you combine those two and say, okay, therefore, what is my level of risk? Then you need to identify specific security measures in the document. And finally, you need to remediate and monitor on an ongoing basis that whole process. So there's a very clearly defined script of 9 procedures that are involved in the entire process. And along with that, so that's what the process looks like, but what you might look for in terms of, okay, what does that all require in terms of documentation? Some of the more common documents that virtually everybody should have would be an overall broad risk management plan, of course, a security risk analysis, which we've talked about, a documented, well-documented data backup plan, a safety and security plan. We talked about that a little bit. An emergency mode operations plan we talked about. Importantly, a disaster recovery plan, incident response plan we chatted about a little bit, just in the event that you have some kind of a threat to patient data. And then finally, I would say a very good HIPAA policy and procedure document. The one that we work with clients are starts about 220 or 230 pages and then expands from there depending on the client. And lastly, I would say make sure you include in all that set of documents some kind of business impact analysis.
Great, thank you. That's all we have for questions at the moment. Melissa, is there anything about meaningful use that you'd like to add before we conclude?
No, I would just say for everybody to keep watching and see the updates that are going to unfold over this year with the new program. Definitely the shift is towards quality and payment for quality and performance. So just be looking for all the updates that CMS will be releasing on that.
Okay. Thank you everyone for attending today's Advize Health webinar on meaningful use and security risk analysis. And thank you, Don, for helping us deliver such an incredible presentation. Everyone should expect to receive an email with their 1.5 CEUs, a copy of the presentation, and a recording of the webinar within the next 35 business days. Advize Health hosts webinars on a monthly basis, so be on the lookout for information about our upcoming April webinar. Thank you, everyone.